whose sole purpose is there is to work with people and make sure that they are healthy and make sure that they thrive in life. And I want to thank all of those folks for all the hard work and dedication that they do to healthcare. With those few comments, I would like to maybe move on quickly to your questions, but I do want to introduce a couple of people that are with me. Of course, most of you know my Deputy Minister, Cheryl Doiron. She will be sitting here whispering in my ear for the next number of hours, as well as my Chief Financial Officer, Alan Horsberg, and of course the staff that are visiting us in the gallery today. So Mr. Chair, with those quick comments, I will take my seat, and I look forward to the questions that will ensue for the next number of hours.
Thank you. The chair will now recognize the opposition leader.
Thank you very much, Mr. Chair. And I have a number of questions that I wanted to have the opportunity to address with the Minister and his staff. And the way I'd like to go about this, and I know that the Minister will forthrightly answer all of the questions as he always attempts to do. But I'm going to go through kind of a number of them and kind of let you stack them up and deal with them as a whole, if you don't mind. Over the course of the last election and over the course of the run-up to this session of estimates and over the course of last year, I heard on the continuing care strategy time and time again as I went around the province, and no matter who I talked to, whether it was doctors or seniors advocates or caregivers, whether it was any of the political parties, everybody seemed to be able to identify the problem. Everybody would say, the problem is that we have so many people who need to be in long-term care facilities who are now in beds in hospitals that ought to be used for other post-surgical recuperation or for cleaning up the problems in emergency. Everybody seemed to be able to identify that this was the problem. And so they would sometimes, to me, very, very frustratingly, they would say, look, everybody understands that this is the problem. Why is it that the government won't simply ensure that there are the number of long-term care beds available so that the people who need the service can get it, and those doctors and patients who need access to these beds in hospitals are able to get access to those beds? If everybody knows the problem and everybody knows the answer, why is it that the government can't seem to make it happen? That's the first thing. The second thing is, and I know because I've heard you say this before, and you have sometimes said to me, Mr. Minister, that, well, we just can't open long-term care beds. And you've said, and I've heard you say, well, if you and I got a hammer and we went out and started building these facilities, maybe they'd be ready sooner. And that's a great rhetorical answer. It's got that nice feel to it, and it sounds great in question period, but it doesn't come within a country mile of actually dealing with the problem. And the problem is, as you know, and I think most people who have spent any time in this sector knows, is that in fact, this problem has been identified community by community right across this province for years. And you can go to Western Shelburne County, and you can go to Barrington Passage, and you can go to Clare and talk to the people at Villa-Acadienne, or you can go to Cape Breton and talk to people in many, many communities in Cape Breton who identify their seniors who are leaving their communities because they can't get the access to the facilities they need. You can go over to Oakwood House and Oakwood in Dartmouth, and they can tell you that they have asked for years for expansion, to build more of these beds. And not only that, Mr. Chairman, the minister would know that many of these communities and many of these facilities have gone so far as to develop proposals that they have made to government. They have had architectural drawings, but in some cases, the government has actually paid for the architectural drawings because the proposals were put forward and then rejected, so they absorbed the cost of the facility's proposal, because that was an unfair thing to happen to the facility and to take up so much of their money. For example, in my colleague's community in Barrington Passage down on the South Shore, they, of course, as he points out many times, they were promised this facility 30 years ago. They have the architectural drawings. In fact, they actually showed up and dug a hole at one point to say that they were going to start the facility. And it just never happened. Now, in the case of Western Shelburne County, the municipalities have actually gone in and they have said that we will donate the land, we will give you the money, we want to be partners in ensuring that this facility gets built. The same is true in many other parts of the province, where committees, nonprofit committees, have been established. They have done the work in their communities. I mean, you only have to go to Middleton to see the dedication of the volunteers in that community, asking the government to do the right thing and to provide the number of beds that they need for that community. And it's a heart-wrenching story that the former mayor of Middleton tells about one of his residents who was taken out of his home because he needed long-term care and was placed in Bridgetown. And he used to go visit him on a weekly basis. And every week when he would go to visit him, the fellow would say, "Can you get me a place up in Middleton? Can you take me home?" He just wanted to go back to the community where he'd worked and lived all his life, where he'd raised his family. And yet, the mayor said, well, eventually the guy died, and I didn't have to feel guilty about it anymore. That's terrible. That's a terrible way to treat the seniors of this province. So, for the minister, there are so many of these facilities where the actual time frame has been condensed because much of this work has already been done. So my question is, why can't those facilities be fast-tracked so that we can get that work done, get those beds in place? Because that's part of the answer to the first question, which I just posed. So, I'm asking this, and I'm not asking for a rhetorical answer. I'm asking for, so I can understand, so the people of the province can understand. The third part of this is, let's say that you say, for whatever reason this can't be done, then I would like to know what process is going to be in place to ensure that the people in Western Shelburne County and the people who were promised out in Lower Sackville and Waverley Fall River Beaverbank, who were promised their facility many years ago, what process is actually going to be in place to incorporate the responses of those communities so that they can depend on a process that's going to actually end up with a facility that is going to meet their needs. So those are basically where I'd like to start on this, and I'm not going to belabor it because I think those are very straightforward questions for the minister.
The Honourable the Minister of Health.
Thank you very much, Mr. Chair. And I'm going to go through a number of those issues as well, and try to bring a bit of clarification to it. And a lot of the question is why has things taken so long? I think it's sort of the underlining question that the member brings forward. And sitting in this position, looking at the time that has transpired, and I do believe it's been unacceptable, the time that we've had to get things in line. But ultimately, that's what's been happening, is that there's been a lot of things being put in line. Continuing care had been inadequately funded prior to this government coming in, so we had to make the address to bring in line the continuing care division within the department to make sure that they had the funding available for the facilities that we had. As a matter of fact, 30% of the homes in the province were ready to go into receivership. We had to make sure that they had the adequate funding there to maintain the beds that we had at that snapshot in time. We also had to work quite diligently and quite a bit on the standardization of pay and benefits for nurses and other professionals within these homes to make sure that they're adequately compensated across the system. So there's very few inadequacies or comparisons from home to home. The continuing care strategy, we wanted to make sure that it was done right, and of course it was done in conjunction with the senior secretariat while they did their consultations on positive aging. It made sure that we met, through 50 consultations with 1,400 different individuals to make sure that what we were trying to embark upon made sense in a short term and long term. And I think that the continuing care strategy, as you see it today, even though it is a work in progress, and it will be one that will require a lot more work over the next number of months and years to ensure that we have the correct facilities in the correct areas. And I think that's the challenge, is that we have everybody asking, and how do you qualify or how do you prioritize those requests as they come to the department? If we take into consideration the Shelburne issue, and one that I heard a lot about during the last election, one that I heard about basically from day one of assuming the role here as Minister of Health, the go back and forth between what department was saying and what community was saying really revolved around what kind of services we were willing and able to provide to the community. Because the number one issue that is important to me within this whole continuing care strategy is to ensure that the seniors get their service to stay at home the longest. And if we look at the way home care is done and the kind of services they receive at the home, the kind of monies that are available for home improvements and upgrading, we want to make sure that all those pieces are in place so our seniors can stay at home where they're more comfortable, where they live out their lives, of course, much more happily and much more healthily for the most part, if they have those services in place. And the second piece to the continuing care strategy that is important is to make sure we have those beds in the correct area. And Mr. Chair, it's really important to say is that we have a number now. We look at the 826. We looked at the 1,320 over the next 10 years, because as this bump of folks are going to increase, the number of people requiring home care will increase. We need to have the beds available. And Mr. Chair, you also need to remember that only about 10% of our seniors over 75, what's the number? 5 to 6% of our seniors over 75 require a long-term care bed. Most of our seniors do live their lives out quite happily within their community, within their homes. And of course, our average age is 83. But ultimately, there's a lot of work that's involved here. Creating the base and then finding out where we're going in the future. But going back to Shelburne County for a second, the concern that I had is that I want to make sure that I have the right services in place, adult daycare, maybe the nutrition program, and those kinds of things, before we committed to a full home of 70 beds is what the community was asking for, and make sure that that's the right decision. And I mean that's my point there. And the member from Shelburne does underline an issue there that it dates back to 1976 when the Brass Hill Manor was basically brought forward. I mean, heck, if you would have been able to show them to us in the house the other day, we would have seen a full architectural drawing, engineering drawing of a home that was supposed to go into Brass Hill. And what happened at that time? Why has it been neglected for such a long time? I don't understand, and it's one thing that I'm trying to rectify as Minister of Health, and it's why we committed to the extra 40 beds over and above the 22 beds or 20 beds that are at Bayside today. But Mr. Chair, I think we need to have a good plan and a good feeling of where our beds are going to be going in this province to make sure that they service our seniors in the right places. And I think that's going to be a challenge, is why the process will be one that we are opening a project office for the continuing care that will just be dealing with construction timelines, where those people are going, how the RFP processes are going as you put the tenders out. there's a lot of work to be done, but I got to commit that it takes about 18 months to construct a facility if you're building any facility. It also costs $183,000 per bed. If you're doing a 20-bed facility or doing something else, the calculation is $183,000 per bed from a greenfield site. So there's tremendous amount of money to be involved, which is why I thank the municipality of Barrington, and I thank Clark's Harbour, the town of Clark's Harbour, for their offer of property and funding. But it is a very small component of what that home is going to cost into the future. So, Mr. Chair, I'll take my seat at this point. I think I answered a few of those questions, and I'm sure the member opposite will ask a few more.
Thank you. The Honourable, the Leader of the Opposition.
Well, Mr. Chairman, there's not a lot that I could take issue with in what the minister has just said, and he's kind of laid out in a kind of common sense fashion, part of the perspective of the department on this issue. But it also underlines one of the key problems in the department in dealing with this issue, because they seem to want to confuse the idea that you're going to have home care and all the appropriate supports in place for people who want to stay in their homes with long-term care. People who have been medically assessed and who the doctors have say need to be in a long-term care facility are not going home. They're not going home. That's not going to, that is part of the frustration in dealing with this, in that, all of those other things are great. I'm very happy that the government has finally got it through its head that you have to have a complete continuum of care that's going to provide people with aging in place supports that are going to allow them to stay in their home for as long as possible, then potentially move to an assisted living facility, and then eventually into a long-term care facility. All of that it's nice to know that is what is on the radar of the government finally, because it wasn't when we first arrived here in 1998. That's for certain. So these are people who have been medically assessed by professionals who require long-term care beds. That's who's in those beds in hospitals, not people who are going home. So let's not confuse those two pieces of this problem. Now, he talks about $183,000 for a bed constructed in a long-term care facility. Well, the cost of a person in hospital, a hospital day, is about $1,000 a day. $1,000 a day. Now, just my math on that is that if you multiply that by 365, you get $365,000. So the long-term care bed is half, again, as expensive as leaving them languishing in a hospital where they don't have access to the kind of programming that will actually provide them with the quality of life that they deserve. So, and I don't think I'm telling the minister anything he doesn't already know. And in fact, it is the same thing that I have heard again from doctors, from caregivers, from, caregiver burnout alone for people, because we have people who are medically assessed, by the way, who ought to be in long-term care facilities who are actually still at home. And there is a real question around whether or not they are getting anywhere near the service that they actually ought to be receiving. And I think that is another level of question that the government has to address its mind to. But let's just set that one aside and deal with those people who are actually in hospital beds. So, Minister, I'm sure you can understand my frustration when you tell me, on the one hand, that this is you want to deal with all of these issues about people who are going to go home, when what I'm talking about here are those people who aren't going home and who deserve to be in a decent long-term care facility.
The Honourable Minister of Health.
Thank you very much, Mr. Chair. And, the member opposite is quite correct in, we have a certain amount, a large number of alternate level of care patients sitting in our hospitals. But the point there is that even if we take that person and put that person into a long-term care bed. We're not closing the acute care bed. So you know what I mean? We still have the cost there, so we're not taking one and paying for the other. And I think that's one clarification that I do want to make there. You know, we want to offer enhanced community services. You know, things that people can go home. You know, that's why we announced the 50 restorative beds. You know, place that people can, after they receive surgery, after they've recovered to a point where they can go off into either home or whatever, that can go and get even better to go into the service. With the doctors, without adequate programs to send them to, will revert to a long-term care bed. You know, if there's no other service for them, you know, you can't necessarily go home. You're going to send them to a long-term care facility, or that's how you're going to assess them. So that's why we want to make sure that we have some of those programs in place. If we take the VIP program that DVA has brought out, and that has demonstrated, it's been absolutely incredible, the change in the seniors that receive care from that group. You know, if we look at the members that were going off to the veterans units, and we do have a few veterans units that are sitting with a few beds vacant at this point, because they are receiving such good service at home, and that's the kind of things that we want to replicate there as well. Also, something just to bring to the floor of this House is simply, since and I guess recent estimates on greenfield construction of homes, it's about $220,000 for new construction per bed. But since 0102, we've seen an increase in home care of about 36%, you know, up of $32 million, and an increase in long-term care since 0102 of $188 million, which is you know, 107% increase. You know, I think we're doing everything that we can within the funding envelope that we can to make sure that we're making long-term care better. Are we there yet? Absolutely not.
The Honourable, the Leader of the Opposition.
Well, you know, it's not up to me to argue with the minister about about these things. I don't think that doctors are purposely misdiagnosing or identifying the services that the people in these facilities, in these hospital beds need. I think they do an earnest job of trying to figure out how their patients are going to get the best care, the care that's most appropriate to them. And it's really clear that many of those who are currently in hospital beds are not getting, and it's the kind of care that that would actually be of most benefit to them. And you know, I had some way the privilege, in some way the very eye-opening opportunity to travel around the province and to visit many of the long-term care facilities around the province, and also to go to many of the hospitals where many of these, and speak to the workers, the healthcare workers in these facilities, who tell me, let me just give you an example of one of the things that I was told, and I found this fascinating. In a very sad way, actually, I must say, that you have people in hospital beds who need to be on Alzheimer's wings or wings dealing in a specialty way with people who suffer from an organic brain disease of some kind or severe senility. And one of the facets of that very unfortunate diagnosis is that they tend to become violent, and they can have violent episodes, mainly out of confusion, out of just irrational behavior, because they have reduced capacity to deal with the stimulation in the environment around them. So the hospital themselves, how do they deal with that? How do they deal with the fact that they have healthcare staff who are going into an environment where they may face possible harm as a result of violent outbursts? Well, Mr. Speaker, or Mr. Chairman, I didn't know this, but what they were doing was that they're hiring security guards. Hiring security guards to come into the hospital and set in the rooms next to the bed of these patients. Now, the first thing that must be said is that the poor security guard that they're hiring has no understanding of the medical condition of the person that is in that bed next to them. My understanding from talking to the workers is that they are sometimes terrified to be there themselves because they don't have, what are they going to do if there is some kind of a violent outburst? It puts that individual in a terrible position. It puts the healthcare workers in a terrible position, and the patient lying helpless in that bed does not get the kind of assistance or treatment or quality of service that they deserve. So that's one of the kind of things that people don't necessarily think about, but it's one of the things that I discovered as I went about the province. And I just want the minister to know that I'm not alone out here. There's an awful lot of people who understand the inadequacies of that situation. And the minister says, well, it takes 18 months to build a facility. I just don't understand why it's going to take 18 months to build a facility when I've already told them that many of these facilities, they bought the land, they've actually got the architectural drawings done. They're sitting there with proposals in front of them that I'm betting you that if I were to get on the phone this afternoon and ring them up, that I could have a half a dozen proposals on your desk tomorrow morning for you to review. If you wanted to fast track some of the existing proposals that were out there, you could do it. And I understand very well that you say, well, how are we going to choose among these? There is going to be a filtering process. Because what's going to happen, you're going to go to Western Shelburne County, you're going to build the long-term care facility in that community, and when you do, a lot of people who are somewhere else in the province are going to start to come home. They're going to come back to their community. And that means they're going to come out of the facility in Villa-Acadienne, they're going to come out of the facility in the Minister's Riding, they're going to come out of the facility in Yarmouth, they're going to come out of the facility in Roseway, and as a result, those beds in those facilities are going to open. And so then people in those communities will have access to those beds. And it's going to take some time as you build these facilities to understand how that's all going to shake out, and I understand that. But that's not going to be a problem for you on the front end. On the front end, you're going to measure how that's going to work out, and I would dare say until you're probably halfway through your strategy, if you recognize the underserviced areas first, that shouldn't be a concern for you. So I just, what I like about the fact that we are here today having this debate in estimates is that when I first came into the House in 1998 and I started raising this issue, you and I, the minister and I would both know that part of that increase in the envelope of funding on this issue is as a result of the government actually recognizing its responsibility to provide health care for seniors in these facilities. Because that's something that didn't happen for a very long time. So, and quite frankly, something that I, as the leader of the opposition and as a member of this caucus, is very proud of having had a hand in make happen. So I'm pleased to this extent that this debate is taking place, that this critical issue with respect to the seniors of this province is actually on the radar of the government in a very significant way. And I think that all the members of our caucus should be very proud of the fact that we elevated this issue to the point where it is now, and I would hope that those people who are in that sector are also pleased that they are now getting what I think is the attention they deserve. I want to move on to another thing which is related but separate to, which is the second part of the issue that you raised, which is all around the whole question of those supports at home for seniors. I forget, and I'm sure the minister will remind me, just exactly what the commitment of the government was over the last election campaign with respect to the training of new home support workers And I guess what I'd like to hear from the minister is, what is the commitment of the government to train new home support workers? How will they be distributed? How will you decide in what communities those are going to be in? And what are the programs that you intend to institute in community colleges or with facilities around the province that's going to yield those home support workers not only this year, but in the years to come?
The Honourable Minister.
I guess I'll go with the last question first, and work my way backwards a little bit into the home care realm, and what we've been bringing forward, what we want to bring forward. Is of course the addition of more continuing care assistants within the system, making sure, and I forget the total number of continuing care assistants that we require. We do need a fair amount of those folks to get out there and help our seniors and work within our facilities. But we also need to work with our community colleges in order to have that kind of training going on with a true recruitment program to make sure that we have the people going into that stream. We also need to look at equivalency and experience, to look at those people that are basically already out in the system or are offering similar services to folks to see how we can integrate them into the system as it stands today. I'll talk a little bit about, challenging behavior and how, we need to do a lot better job when it comes to working with Alzheimer's and other challenging behaviors. And we've invested about $225,000 this year in trying to expand the challenging behavior program, and a program that will be included an 8-member provincial resource team. And we don't have the resources or the people within the system that can work with all the different homes and areas to provide the correct service to these folks. Because as we all know, that those of us who had the opportunity to visit some of our seniors that do have these challenging behaviors. I was at the Villa Acadienne, the chairman's in the chairman's riding. I visited the Titleview Manor in Yarmouth and checked out their facility. And some of those facilities are not adequate for the kind of care that they're providing, and that's why we want to make sure that within the strategy and what we're trying to bring forward this year is to have at least a standard of care across the province when it comes to challenging behavior, which is why that we want to have this provincial resource team that can go around and providing training and those kinds of things to our areas. But we also need to be cognizant that we need to do a lot of upgrades for these units. These units, Titleview is a good example of one that has too many people in it at this point, and just has the facilities that's required. We do also have areas that don't have a facility at all, and something that we need to address over the next number of months and years. If we look at the construction versus RFP process, or whatever process that we put into place on the construction of long-term care beds in our communities, the 18 months is I think a realistic time, because not only do we have to get these architectural drawings that some do have, they'll happen faster, which is great if they can get those proposals in, and they can be accepted by this provincial coordinator, and by the process that will be set forward, and it'll be brought forward to the members of this House for their interest and their information. Mr. Chair, I do want to say that we already have 125 beds, or 410 new beds that are already under development in Cape Breton, Colchester, and Capitol Health. So already about half of the 826 beds are already in some form of development. So I'm going to have to add Shelburne County to that list, because we have 40 beds under development in Western Shelburne County as well. But Mr. Chair, I do want to say also is that that there has to be a strategy in the meantime. Before we can have these beds constructed, these seniors deserve more than sitting in a hospital with all the noise and all the things that go along in a hospital. And I don't know how many people in this House have been had to spend any time in a hospital. I know that's not a great experience, and one that we shouldn't ask our seniors to do for any length of time. But in the meantime, we need to find services and places for these folks. And through the district health authorities and what we call the alternate level of care is that they are developing areas within the hospitals that are more home-like settings, places that are a little more comfortable, that are a little less busy. Last year we provided $3.6 million to the DHAs to make either renovations or changes to wards that are underutilized. And that has been added to the base of this year's budget as well. So there'll be another $3.6 million to go forward to continue this interim strategy until we have all the beds that we require into the system.
The Honourable Leader of the Opposition.
You know, Mr. Speaker, it's been my observation in the last 7 years or so that I've been in this House that no department is as good at getting a euphemism out than the Department of Health. Under development. These are beds that are under development. These are beds that are not being built. And I don't know what under development means, but it means, for example, that the beds that were promised in Lower Sackville, in that area, Bedford area, have been promised for years. They've been under development for years. And that's what people find so frustrating, is that they get these euphemisms for why it is that they're not going to get what it is they need in order to service their loved ones. And so the minister, in the answer to the home care, home support question, kind of meandered back into the long-term care question. So I'm going to follow him on that, because I didn't quite address the whole question of what happens when you build a long-term care bed. You don't get rid of the cost with that bed because you're not going to close the bed. Now that's very true. And if that's your reason for not doing it, then you should say so. Because people do understand that is the cost. Those beds are going to be open, but what that means, I think this is what doctors find so frustrating with that answer, which is that if the answer is we're going to leave them in this bed because if we move them out to a long-term care bed, the cost of that bed is not going to go away. Well, that is a tremendous misuse of departmental resources. That is using a very expensive bed to service or to try and service a person who in the end is not going to even get the kind of service that they require. It's not just doing a disservice to the individual who's actually in the bed, it's doing a disservice to all those other people, those potential patients, the doctors, those people who could be providing an appropriate service that would use that bed. And I know those beds aren't going to go away, but what you would be doing is you would be using those beds for the service for which they were intended instead of for an alternate service for which they were not intended. So let's just try and put a close to that particular argument, because if it's one you want to make, then make it clearly. But I don't think it's a very good use of departmental resources. The minister went back to talk a little bit about challenging behaviors, and he reminded me of something in those facilities when I went around the province to talk to people that I should raise here as well, because he should know this, that there are facilities around the province who are actually not asking you to increase the number of beds. They are asking you to increase their allocation to their particular facility for two reasons. One is because their facility is now inadequate to house the people that they have in them, because they were built back in the 1970s and they have double rooms that are small, and they are now having people in those rooms whose acuity level is far greater than they were in the 1970s. Some who suffer, as I said, from Alzheimer's or from other disabling diseases. And what they want to do is they just want to expand their complexes so that they can turn those doubles into singles, so that the people who are in their facility can actually get the service the appropriate level of service that they deserve. And I want the minister to think for a second, because I know that that I'm sure people have thought of this. If you're, whatever age you are, let's say you're 70, and you've lived independently all your life, and now because of medical conditions that are beyond your control, you need what's that? I'm asking him to project forward. That you need this service in a facility. You're a modest private person. And for the first time in your life, you will be taken to a facility and placed in a room with a complete stranger. That's a tremendous strain for some people. And those are the kinds of things that are being dealt with by administrators right across the province in their facilities, in many of their facilities, not in all. Some of them are new. I know the new facility in Pictou is beautiful. It's well designed, well laid out. As I went through that facility, I thought to myself, if I was going to be in a facility, that would be it, right? It's one of the nicest, I think, in the province. So what they're asking to do is not to increase the number of beds, but to have an appropriate facility for the people that they have to serve. It's the first thing. The second thing, and it relates to the first thing, which is that the acuity levels in these facilities are so much higher now than they were when the facilities are built. But you know something? The staffing levels haven't changed, or they have changed very, very modestly. And I've been in these facilities, and I have had the administrators say to me, "I wish the Department of Health would come here and audit my facility and see if they think that the number of staff in this facility are adequate to provide the service that the people in this facility need." I've had administrators tell me that. I mean, I was quite surprised. I thought, in fact, that the administrators would be reluctant to have that evidence come to light, but they're not. They want you to know that there is a problem with their staffing. Because as the administrator in Bridgewater told me, when they built their facility, they expected to have 25% of the people in that facility who were going to be what they considered to be heavy care, and 75% to be lighter care. Here we are years later, and exactly the opposite is true. 75% of the people in the facility need heavier care, 25% need a lighter level of care. And I want to be absolutely clear, these are well-managed facilities that have volunteer boards that work extraordinarily hard to support them. Their reality has changed, and they are asking the Department of Health for assistance in ensuring that their citizens, the people that they're trying to serve, are getting the service that they need. And finally, since we're on that little piece again, and I know that there's one more thing I wanted to get through before time runs out, or my hour runs out. Finally, the other thing that's interesting about these facilities is many of them have a respite bed, or maybe two. I don't know if I ran into anybody with two, but maybe there are. And what's that designed to do? Is that's designed to assist people who are currently caring for someone at home, and they want to get a break, to get away. Maybe they're going on vacation and they can't take their loved one with them, so they will apply to the facility to use that respite bed while they're away. But there are often very, very confining rules with respect to how long they can use the respite bed, under what conditions that can happen. I mean, that's part of that connection to the community that the department should be trying to ensure is there in an appropriate way. So we just covered off some of those, and I'll just ask the minister to respond.
The Honourable the Minister of Health.
Thank you very much, Mr. Chair. And just want to say that we're going to be focusing, we talk about respite beds and families taking care of their loved ones at home. It is something that we want to invest a little more in, a little more time to make sure that we have the caregiver strategy that makes sense, that will encompass the idea of respite and added home supports. because I think, if you can stay at home and you have somebody that does want to take care of you, or why not take that opportunity, because you know that the care that they're going to get is going to be absolutely second to none. If we talk about the homes and what homes were originally designed to do back in the 70s, and there were a few in the 80s, but not so many. They were built as two beds to a room, and I can't imagine the traumatic feeling it must be to move into a room to share your life with someone when you hadn't been, or you had been sharing it with your husband or wife over a very long extended time. So you really have to get used to the habits of another person, and I don't think that's ultimately acceptable. If that's what we have and we have to work with it, that's what we have. But ultimately, as we move on to these new beds, that there will be as many as possible of these separate individual units like PIC2. And I'm just wondering if maybe we should put you on the list for PIC2. We'll get it on now, and we'll try. Just funny. It might take that long to get on the list. But I do want to assure the member that as we talk about adding the 826 beds across the system, we're also talking about 1,659 replacement beds across the system, because there are facilities within this province that were constructed, the 1800s.
30, 40 years ago.
There are some really old homes, and there are some homes that are just of course. Member yesterday brought up the issue of Glades Lodge, and the challenge that they have there on mechanicals, and and quite honestly, that home again is a two bed per room type facility. So as we look at replacement, I think that's something that we need to bring forward relatively quickly within the next few weeks to make sure that the money's in place, the process is in place, and get on with the business of construction. Because I think as we move into construction, you look at the boom that's happening in this city, and it happens in a lot of areas around the province, that a lot of our construction companies are busy, and we need to be able to get on their lists in order to get construction going. So with that, Mr. Chair, I think that sort of covers some of the issues that the member brought up, and just when I think of palliative care, you did bring up palliative care there, did you?
Yes.
Okay. There's about $3 million more and $1 million in this year, so $3 million over the next number of years, next 2 years, on making sure that we have a palliative care program that is at least equal across the province. From the Southwest, and the member for Shelburne could probably attest to that too, that we really didn't have a palliative care program in Southwest, and we want to make sure. Oh, that's respite. Well, let's talk about palliative care for a sec, and make sure that we that have a system that makes sense for those folks that are moving beyond the care that can be given in a home, but one that we have to give some comfort and some help to the families and those types of things. And as we're trying to invest, there we go, there's the right number, $832,000 this fiscal year, and about $2.2 million over the next fiscal, on enhancing the palliative care services in this province. It's one that's very important to me, and I apologize for that. But let's go back to respite for a sec, where we're investing $3 million over the next 2 years to improve and expand the wide range of those services in respite, to make sure that we have the adequate beds for respite, and we have the adequate services there for you. This is recruitment for the CCAs. To go back to that issue for a second, is that we're looking at hiring another 230 CCAs over the next 2 years, which is about an investment of past years, which is an investment of about $72 million. There's $900,000 in the base budget for bursaries, for recruitment and retention in continuing care. So there's some fair amount of initiatives for those continuing care assistants to make sure that we have the folks available to take care of our seniors.
The Honourable, the Leader of the Opposition.
Well, thank you very much, Mr. Minister and Mr. Chairman. So this question, I think, is going to be hopefully a little easier for you to answer, and a little fresher information. So I've been intrigued, as I think many people were at two of the things that the government has talked about introducing over this year and next year, and that is the expanded pharmacare program. So dealing first with the children's pharmacare, I wonder if the minister could explain to us how that's going to operate, whether or not there's going to be a premium paid by families, whether there will be a co-pay on the children's pharmacare program, and we'll just start with that.
The Honourable the Minister of Health.
Thank you, Mr. Chair, and I apologize for not standing up quickly, but I just want to make sure I have the information correct as we go into this. As we talk about the children's pharmacare program that was talked about some time ago, which I think was to encompass about 30-odd thousand children in the province that don't have that kind of service, and also moving into the Families Pharmacare program. We are working in design at this, starting to work into design with the Department of Community Services on that. So a lot of the details are not set yet or not available, so it would be hard to comment on that. But if we look at how our seniors pharmacare program is done, and how those needs assessments done, I think they will be quite similar.
The Honourable the Leader of the Opposition.
The pharmacare program that exists now is within the Department of Health. So are you saying that the children's pharmacare program will not be within the Department of Health? It will be in the Department. I'm just wondering where in the estimates I'm going to find the money that's associated with the children's pharmacare program.
The Honourable the Minister of Health.
But I'm thinking that. Just to answer the question, just making sure that the Children's Pharmacare Program was one initiative brought forward by the Department of Community Services, and I think you'll find that in the budget lines of Community Services. Okay.
The Honourable the Leader of the Opposition.
Okay. So then, do you know whether, I mean, the pharmacare program as it exists today, the current pharmacare program that deals with respect to seniors pharmacare, is contained within the Department of Health's budget. So will I think it was called the Working Families Pharmacare Plan, will that be within the Department of Health, or will that be within the Department of Community Services? And it strikes me as, and let me just say, first of all, it strikes me somewhat odd that that would be in the Department of Community Services if it's meant to be a broad-based program.
The Honourable Minister of Health.
Thank you very much, Mr. Chair. And at this point, there are two pharmacare programs in this province. One of them being the Seniors Pharmacare Program, which is housed under Department of Health, and there is the Community Services Plan, which is housed in Community Services. And as we talked about the Children's Pharmacare Program, that was an initiative of Community Services. So I think the intention originally was to sort of design something that would probably stay over in Community Services. And we were just basically providing oversight on the formulary and the kind of drugs that are in it, and providing just oversight for them. But I think with the platform promise of the Working Families Pharmacare Program, that we're looking at an option right now to combine those two ideas to provide a more comprehensive program for everyone, and try to combine those. So I would think that through the next number of weeks, as we sit down with Community Services and we come up with design of the program, I think you'll see a combination of those. And I would think right now, and not to get out ahead, it would make sense to have those programs residing under one roof.
The Honourable the Leader of the Opposition.
Well, I'm not sure I'm better informed right now than I was when I stood up the first time. But I guess then the question I would have would be around implementation dates. What are where is the department or where is it at in its expectations of when these programs are going to come on stream?
The Honourable the Minister of Health.
Yeah. Yeah, no, I think as we sit down and work on design, the timelines, as I understand them right now, is that the Children's Primary Care Program was originally slated to come into being, I think, sometimes late this year. But as we go along, do we put one program in place that is going to end up being encompassed by another program? So do we design them congruently or not? As the member opposite is very well aware that the Working Families Primary Care Program was a platform commitment, and the timeline on that is to try to work on that one and have it in place by sometimes next year. So as we roll forward on design, I'd be very happy to bring that forward to the member opposite to explain what the program is going to look like as soon as we have those details.
The Honourable, the Leader of the Opposition.
All of these, all of this program design obviously is complicated, and because the experience with the seniors pharmacare program is that program, in terms of its point, well, it has two things that are happening with it. One is it's becoming exceedingly more expensive to the government, because the cost of drugs continue to go up, and part of that actually has to do, as I think you would agree, with the extension of patent protection, which took place at the federal level, and that became a problem that was essentially downloaded into the provinces. So that's the one thing. It's become more expensive for governments, but it's also become more expensive for seniors as they've seen co-pays go up, as they've seen the premiums go up. And there's a very interesting thing that happens with that particular program. And if a senior applies for the program, and if they don't have enough individual income that they have to pay a premium, then they don't have to pay a premium, and they receive their drugs. I think they still have to pay the copay. However, and you can have both seniors in a household, both under the threshold, right? But then what the department does is they add the two incomes together, and then the two incomes exceed the threshold, and then they have to pay a premium. Individually, they're fine, but their combined income exceeds the threshold. Why is it that is designed in that fashion?
The Honourable, the Minister of Health.
That has been part of the design. I don't know why.
I mean, that's the point there. Yeah. Thank you, Mr. Chair. As we look at the Seniors Primary Care Program, which does cost a fair amount of money and has an increase year after year of about 10% per year, it does bring a huge benefit, of course, to our seniors. As for design, when we combine the two incomes, is one that I'm not too sure of, but I can provide the member opposite with some further details on that, and if there's maybe something we're missing here that we can try to alleviate or fix. But approximately 40,000 seniors pay a full premium on that, and approximately 14,000 seniors pay a partial premium, and approximately 40,000 seniors pay no premium at all because they receive either GIS or they're in nursing homes. So it's been a tremendous benefit for seniors, but it is a costly program for Nova Scotians. I do want to talk quickly from our dealing. If we look at that kind of cost for seniors, if we take the 132,000 people or so that we would feel that would benefit from the Working Persons, Working Families Pharmacare Care Program. Got to find a silly acronym for that to be easier to say, but pretty much it would cost us somewhere in the range of about $90 million, and that's just a quick blush calculation on that, and one that hopefully will bring some more details forward as we work on program design, and but that's just extrapolating what we're paying on pharmacare and work it into that number of people. But also, as we talk about drug and drug costs. It is one that I had the opportunity yesterday to be at a federal and territorial and provincial meeting and talk about NPS, which is the National Pharmacare Strategy, which all First Ministers have engaged upon and asked the health ministers to come up with a strategy that talks about a number of things. Catastrophic drug coverage, which there are far too many people across Canada that they're just unable to pay for the drugs that are prescribed to them so they can have better lives and be in better health. Talking about really expensive drugs for rare diseases. There's getting to be a number of different genetic issues that drug therapies are costing the hundreds of thousands of dollars, if not. There's one, George Smitherman, who's the Minister of Health in Ontario, tells me of one that costs somewhere close to $1 million in his province per year. Do we have the facilities to provide that? Do we have facilities to talk about generics and find some cost savings in that to try to distribute across the system? So when we come to pharmaceutical costs and looking at the issues of designing the correct pharmacare program for our folks, I think it's going to take some time, but we should have some further details for you in the very near future. And to my point, I will have some more details, by either the end of today or tomorrow, because they tell me the staff's very efficient in getting answers back when we don't have them on the floor.
Thank you. The Honourable's time has expired. The Chair will now recognize the Honourable Minister of Health Promotion and Protection on an introduction.
Mr. Chairman, I'm pleased to be able to make this introduction during an unusual opportunity here while we're in Committee of the Whole. But today we have with us, joining us in the gallery, in the Speaker's Gallery, a number of players that were subject of a resolution earlier today. We have James Shepherd of Lower Sackville, who was chosen 9th round overall for the Minnesota Wild in the NHL entry draft. Brad Marchand. Brad Marchand, who was drafted by the Boston Bruins. He's from Hammonds Plains. Ryan Hillier, also from Hammonds Plains, was drafted by the New York Rangers. Adnu Bodnerchuk from Hammonds Plains was drafted by the Boston Bruins as well. And joining them are a number of very supportive family members and Bill Short, the Player Development Officer with the Hockey Nova Scotia. And if I'd ask all members to give them a warm welcome and welcome to the House.
And a warm welcome to all our visitors in the gallery this afternoon. The Chair will now recognize the Honourable Member for Glace Bay. Order, please. Order, please.
Thank you, Mr. Speaker. I can understand the excitement, because if he plays where he's going like he played with the Eagles, then he's going to be a heck of a hockey player. We all love the Cape Breton Screaming Eagles. So it's a great experience, and I welcome our visitors as well, Mr. Chair. Mr. Chair, it's a pleasure to be here as usual, and to take my place during the debate of estimates, and with the minister, with the deputy minister and staff as well. It's always a pleasure to see the deputy minister, because I think I can say without any bias that perhaps we have one of the more capable deputy ministers within the country that is at the Department of Health right now. So. And believe me, Mr. Chair, I don't give out that kind of compliment too often, let me tell you. So I hope the Deputy Minister feels rather special at this time. Mr. Chair, I'd like to take a few moments just to address some of the issues that are contained within the budget. And Mr. Chair, I don't know if there's any subject that perhaps would be more important to talk about at this point in time, but than that of health. There are always important issues that we deal with on a regular basis in the Legislative Assembly. But the issue of health and the Department of Health is something that at one time or another is going to impact on us all. It impacts on our loved ones. It impacts on everyone in this province. And Mr. Chair, as you can see, again this fiscal year, the cost of health is going to rise, or it rose already, about 8%. 8% is the figure. So the total budget for the Department of Health now stands at about $2.8 billion. And that's about 1.2 billion more than back in 1999. And I use the reference to 1999 because that's when the Conservative government came into power, Mr. Chair. And I think that actually speaks volumes, Mr. Chair, because first of all, it speaks of the issue of sustainability. And sustainability is a couple of years ago, I can recall, when I stood in this legislature, I talked about how the system was unfortunately about to collapse on itself, and the issue of sustainability. And at that time, the budget was just a mere $2.3 billion at that time. So with the increases now, $2.8 billion. So $400 million. $400 million. A staggering figure for most people to even comprehend. $400 million, and 2 years later, and I would suggest that the same questions that I posed back then would be equally applicable today as well. And I talked about the fact at the time, Mr. Chair, that there was very little investment in the components of health care that would have reduced the burden on the acute care system. And I think, and you know, I'm seeing the minister nod his head, and I know that the minister agrees with that, and I know that the official opposition agrees with that it's something that we have to look at in terms of investments in continuing care programs, such as home care, long-term care. They were minimal then, but we have to change that. We have to change the way we do things. So with that in mind, Mr. Chair, when you see a continuing care strategy that we see today, the reality, the unfortunate reality of that is that the healthcare system will not see the full benefit of such a strategy for the next 10 years. And 10 years, Mr. Chair, I don't have to tell you or anybody else here, is a very long time. And a healthcare system that needs long-term care beds today won't have access to them. And the acute care system that's struggling just to keep up with the needs continues to receive more money, yes, but unfortunately, the funding that it receives in many cases just maintains the status quo. That's all it does. And we are struggling to do exactly that. There's not a lot of new programs, Mr. Chair, is what I'm saying. There's the maintenance of the old programs, which is where the problem occurs. So, you know, Mr. Chair, I often wonder what has happened since 1999. In 1999, when this government was first elected, they were elected on the premise that health care did not require any more money, so to speak. Just a little bit of a dash of investment and some good old-fashioned planning, we were told, was all that was needed. Where are we today? Well, Mr. Chair, oftentimes you hear expressions of concern from residents that, number one, they're not able to access the system. Worse yet, you hear from patients that finally do access the system, and they're being wheeled into surgery and then told that their surgery is canceled. The likely reason there is probably a lack of not enough hospital beds. And Mr. Chair, an example of that, and I would suggest a perfect example of that, is a correspondence that I received, and I will chair it. I will table it, sorry, Mr. Chair, after I finish reading it. But it's from, and the minister was copied with this correspondence as well. It came from Mr. Simon Chesson in Bedeck, Nova Scotia. And Mr. Chesson wrote to the minister, and he said that in October of 2004, his general practitioner recommended that he see an orthopedic surgery regarding a knee replacement. He waited for an appointment, and in June of 2005, in Dartmouth, which was a 9-month wait, got the appointment. He decided that what was needed was a total knee replacement, and he was scheduled for surgery on April 26, 2006. Another 9-month wait for the surgery. He had to be in Dartmouth on Monday, April 24th at 8 o'clock in the morning for some pre-op testing. And then because the OR time there was scheduled for 9 o'clock on Wednesday the 26th, what happened is that he and his wife at that time had to find accommodation for 3 nights. So after 18 months, in his words, after 18 months of pain and limping and a change of lifestyle and 3 trips to Dartmouth, this is from Bedeck, 3 trips to Dartmouth, he finally was going, he thought, to receive his knee replacement and get on with his active life. This gentleman leads a very active life. At 4 p.m. on that Tuesday, he found out that his surgery had been postponed. So you can understand he was frustrated, he was disappointed, and to some extent he was angry. He went to the Dartmouth General Hospital. He spoke with the director of nursing there in charge of OR scheduling, and also the orthopedic surgeon. The reason that he was given for his postponement was that although there was operating room time available, there would be no bed available for him after the surgery. They couldn't give any definite time frame for another surgery date, so they said it would probably be within another month. And they couldn't guarantee that whenever he was rescheduled, whether or not that same situation would happen all over again. So, he was still in pain, still limping, still suffering. He was about $500 out of his pocket in travel and lodging and meals. And he was frustrated. And that's why he would write in his correspondence to the minister that this is an absolutely disgraceful and unacceptable situation. Day after day, that politicians and bureaucrats assure the taxpayer that wait times are being shortened and that health care is being steadily improved by throwing more money into the system. So he's living proof, in his words, that wait times in this province are not improving. In his case anyway, as a matter of fact, they've been extended. Now, Mr. Chair, I'll table that for the House to see, but I think that's probably a perfect example of the situations that exist in this province now. And it's not, I know for certainty, and the minister knows, and we all know, that's not just a lone case of someone who came to Halifax looking for surgery at some time. That's probably an example of many, many. It happens not only just, he happens to be from Cape Breton. I'm sure it would be the case for people from Yarmouth or Digby or on the other end of the province as well, that they'd be coming to Halifax at the last minute to have that surgery, to have whatever it is canceled. Through no fault of the nurses, through no fault of the doctors, through no fault of the hospitals. It's simply a matter of there are no beds available. So you see the crunch, and you can see what can happen, Mr. Chair. And, you know, I would suggest, and not to be too political, but I would suggest that back in 1999, when this government came to power, if there was a time to start planning how to take on instances like that and cases like that, it was probably then. That was probably the time to start planning, not today. It's, you know, we as a Liberal caucus warned the government a couple of years ago that the system is facing a crunch. It wasn't a secret, and I don't mean to be, you know, I'm not being rude here, I don't think, by saying that it was no secret to anyone on the government benches that was happening and that was going to take place, because I remember at the time there were some members that told me I was being overreactive. And I couldn't understand anybody saying that to me to begin with, but you know, it turns out, not to crow about it, but it turns out to be true. Every year, Mr. Chair, we hear the same thing from this government, that they're proud of the investments they're able to make in health care. And I know they believe that, and I know there are investments made. But unfortunately, sometimes, as I've said, sometimes those investments go to maintaining the status quo instead of making genuine investments in the system. Which is why I'm saying, Mr. Chair, that there needs to be some improvements when it comes to that. And I do believe that there are a few good initiatives contained within the budget. Sustaining funds to continue with priority primary health care initiatives, that's important. And I look forward later on during this hour, Mr. Chair, of asking the Minister some questions with respect to that initiative as well. And I believe that funding provided for programs such as self-managed care is extremely important. And again, I'm not boasting, but that was a Liberal bill that was passed in this legislature, and it's a prime example, I feel, of what you can do, spending both effectively and spending that is efficient as well. There's no doubt in my mind, Mr. Chair, that for disabled people in this province, that program has most importantly improved their quality of life. And it has and it will save the health care system money. And that's, I guess, I don't like the phrase, think outside of the box, but I guess, if you're going to, that's the kind of thing that has to be done within the healthcare system in order to make any change. There's a side benefit of, for instance, self-managed care. It frees up some resources in home care programs for other clients as well. So if you look at it from that aspect, and it's an initiative for which I know myself and my colleagues in the Liberal caucus are extremely proud to have been able to support. It was, ironically, Mr. Chair, it was a program that was promised by this government back in 1999. And it took until 2005 to get there. But I'm pleased, even though it was a long road, I'm pleased to commend the government and the minister for finally listening and bringing forward what is a very important program. There are more initiatives, Mr. Chair, within home care that need to be done in order to strengthen and improve our health care system. And some of these initiatives don't really require a lot of money. I know, probably like most members in the House, that I get a lot of calls from individuals who have concerns that their home care workers, for instance, change frequently. It's especially distressing for seniors. They build a trust with the workers over the time that they're with them, and when they experience frequent changes, that doesn't really make any sense to me anyway. Why home care clients are not allowed to see the same workers, because logically I think it would be easier to schedule the same caseload to the same worker on a daily basis. But I'm, again, looking at it from the outside in, and it just doesn't seem to make common sense anyway. I think it would be easier for the employer, easier on the employee as well. Mr. Chair, from a health perspective, it would make sense for a home care worker to detect probably some subtle changes in the status of the patient if they're familiar with the client or whatever. So it's something I get a lot of calls about. And I recognize that's probably not an issue that's a direct responsibility of the minister, but it's certainly an issue that I think he could bring forward maybe to the company or companies that are providing home care services. And Mr. Chair, another area to look at is the reinstatement of, in some form or another, of the old in-home support program. Now, it was canceled in the year 2000 by this government, and there hasn't been a replacement announced, but it would be interesting to know, and I will question the minister again at a later time as to whether there's been a benefit analysis that's been done with regard to that program as well, and how long did it take before clients who were receiving the program in the past ended up with a nursing home bed, and if there's any benefit to reinstating the program, for instance, how many resources in the home care budget could be freed up to expand to other programs and so on. Mr. Chair, sometimes during the many people that we meet as members of the Legislative Assembly in our own communities back home, sometimes you run into certain people that they strike a chord, and you remember them for different reasons. And I'll never forget, it was only about a year ago, I'll never forget running into Mr. John McNeil at the Glace Bay Hospital. And Mr. McNeil is a true gentleman, a great person, worked all his life in the coal mines of Cape Breton, and retired. I don't think Mr. McNeil has ever had a complaint about anything in his life. I don't think. He was just one of those people that was glad to have had the work. He was glad to be in good health. He was glad to be retired. He still is a quiet person that really doesn't like to complain. But unfortunately, his wife Blanche got to the stage in her life where she needed to get into a nursing home. And she was hospitalized, and as of a couple of weeks ago, anyway, I haven't checked in the last week or so, but I will. As of a couple of weeks ago, she was still on the 4th floor of the Glace Bay Hospital, which is the area used that the hospital uses as, I forget the technical name of it right now. Anyway, alternate level of care. Thank you, Mr. Minister, and I'm glad you're up on it. That's what it is, and she was there, and Mr. McNeil stopped me in the outside of the elevator at the Glace Bay Hospital. And as I said, he's never called my office before that time, and he stopped me and wanted to talk to me and asked me if there was anything I could do in perhaps helping his wife be transferred to a facility in Glace Bay. Now we know within that structure that we know, I think most of us do anyway, of the 100-mile radius, the rule that involves if there are no beds available and so on, that perhaps you'd be your bed would be located quite a distance from your home. Mr. McNeil's only worry in his life at that time, and to come up and approach me out of the blue, his only worry was that his wife Blanche would somehow be put in a nursing home that wasn't close enough for him to visit. In other words, if it was in Bedeck or whatever the case may be, within that radius, but still far enough away because he couldn't afford the gas to travel and go see her. And he knew that. He's on a fixed income. His wife is on a fixed income. They simply would not be able to afford the money to purchase gas with gasoline prices rising in order for him to go and see his wife, perhaps. And he was worried. He was very worried about the fact that what he could do. Now, as we all know, Mr. Minister and Mr. Chair, we know that our hands are pretty well tied when it comes to that. We can make the phone calls and we can lobby and we can ask and we can write letters and whatever, but the fact of the matter is the numbers don't lie, the beds aren't there, and what can you do? Simply hope for the best and hope that things work out. I mean, Mr. McNeil understood that, but he wanted me to do what I could, and I did. And as I said, I don't know exactly how it's worked out yet, but I'll find out. But I think that is another example of where we are right now in terms of long-term care and in terms of where we're headed. Now, Mr. McNeil's case is not going to be helped by a strategy that runs over 10 years. I'm not saying it can't. It may be that new beds in Cape Breton would help Mr. McNeil in this case, but the numbers just simply aren't there. If you ask anyone involved and working on the front lines, the people who know in long-term care in that industry, they'll tell you that the numbers that are proposed over a 10-year period don't amount to a drop in a bucket. They don't even scratch the surface. And that's where the problem lies, Mr. Chair. Another area that I think warrants some comment, and again, we'll have some questions on that, Mr. Chair, is the patient health record. I don't know if anyone else feels like I do when it comes to this project, but it seems to me that it has been a very long time coming. But the benefits when this program is fully operational are going to be immense. So I'm hoping, Mr. Chair, that when it's fully functional, I'm hoping that the Capital District will be able to talk to and receive information from all the other DHAs Because, Mr. Chair, it would make absolutely no sense if that was not the case. It would just be a waste of time and a waste of a tremendous amount of money if that's not the case. And you have to take into consideration doctors' offices and whether or not we're going to see them connected to the system. That, to me, Mr. Chair, would sound like another critical link that you'd have to have there, one that would require some planning. So I look forward to asking the Minister some questions as to where they are in the planning process when it comes to physicians' offices. And then, Mr. Chair, there are issues and initiatives that would make the healthcare system a much better system in the future that have been just waiting patiently. Some as long as that magic year of 1999, they've been waiting very patiently to be recognized. There are professions such as midwives, and there are dental hygienists who could play a valuable role in our healthcare system. Their time has come to take their rightful place as professionals in our system, Mr. Chair. Over the past year, our healthcare system has seen some changes that occurred as a result of blockages in our acute care system. And Mr. Chair, I speak of the increased number of private practices, or clinics, I should say, private clinics in our province. And the government did promise legislation to protect Nova Scotians last year. We've yet to see movement with respect to that legislation that would prevent the problems that it was aimed at preventing, such as queue jumping. Mr. Chair, one of the issues not talked about or outlined in this budget, but I again look forward to questioning the ministers on the issue of health human resource planning. Emergency room closures, Mr. Chair, it's an issue that requires more answers, and again I look forward to asking the minister. We pointed out yesterday in question period that it's close to 2 years now, close to 2 years of actual time that emergency rooms throughout this province have been closed. Over 16,000 hours of emergency room closures in Nova Scotia. And I know that it's a frustrating experience for the Minister of Health. And it was a frustrating experience for the minister before him, and before the minister before him, before her, and before whatever. 4 ministers is what I'm trying to say. 4 health ministers have had that same problem in this government since 1999, over 7 years. And I can understand why, and it would be very easy for the minister to stand and throw his hands in the air and say, tell me what I'm going to do about ER closures. Go ahead, let me know. I don't know what to do. I'm not quoting him, Mr. Chair. I'm just saying that it would be very easy for him to do that. And I'm sure the department staff has struggled with this issue as well. I don't know. But the other day, and I'm sure it may have been just one of those moments in question period, but I know the answer is not call 911. That's not even close to the answer, Mr. Chair. I know that the health department is a department with a number of pressures on it. I know that. We all realize that in Nova Scotia. It's a department that also has, in my opinion, some great potential as well. And it'll require leadership, it'll require dedication. And Mr. Chair, I look forward for the next approximately half hour anyway of questioning the minister for some specific budgetary issues, and as well as some general concepts as well. Mr. Chair, let me address the minister. The province has increased funding for primary care programs by 3.3 million over last year's budget. Now, according to budget documents, this money was to sustain funds to continue with priority primary health care initiatives previously funded through the Federal Primary Health Care Transition Fund. And this province received a total of, I believe, just over $17 million from the Federal Primary Health Care Transition Fund. Nova Scotia was also to benefit in a multi-jurisdictional funding envelope that saw New Brunswick take the lead in a self-care telecare program for Atlantic Canada, and that was an additional $6.9 million. So, Mr. Chair, perhaps could the minister please indicate where the additional $3.3 million is going to be spent over the next year?
Thank you. The Honourable Minister of Health.
Thank you very much, Mr. Chair, and I thank the member opposite for his lead up to his question. And I think I will answer his question, of course, but maybe make a few comments on some of the comments that he made. I do want to thank him for recognizing my deputy and put her in such high regard, because definitely a job that requires a lot of time and a lot of dedication. And I myself want to thank her for her work at the Department of Health, because it does take a fair amount of time and concentration to try to pull this off on a day-to-day basis. The member opposite talked fairly at length on a lot of issues, but one that, that as we go along is very important is, of course, the growth in healthcare, and looking at an increase of close to 8% in this year's budget alone. It was 8% last year, and it was 8% the year before. Not only is this happening here in Nova Scotia, this is happening nationally. It's happening internationally. The escalating cost of healthcare. And why is it happening? Is for a whole bunch of reasons. Have everything to do with making sure that we have the correct remuneration for our health professionals, the recruitment of those professionals, making sure that we're paying the same for one in an area and one in another area. Cancer costs. Cancer costs and cancer drugs have been increasing by an exponential number over the last number of years. 25%, I think, this year, which is absolutely crazy if you look at it. But I think our residents deserve to have the best cancer care that they possibly can have, and to have the pharmaceuticals, the drugs that are required to make them better, or at least to make them cope and make their lives as comfortable as possible. We talk about closures and lack of professionals, and really, if you look at Nova Scotia, if we take a true physician slash specialist versus population, we do have the second highest rate in Canada, which was a revelation to me as I moved into this portfolio. But I think we have a problem in maybe distribution of where those professionals are. But as we talk about closures, and I know this is frustrating to me, and it's frustrating to the member opposite to see ERs closed down for a weekend, or for we take the Strait Regional Hospital, probably over a month's time that facility will be without its doctor as she moves off to India. I think it's India, to do a month's service there before she comes back. So I think there needs to be a little better strategy and communications between the District Health Authority and the hospital and the Department of Health to make sure that we have the correct type of personnel in that area, so that doesn't happen. We talked a little bit there about wait times, and the wait time strategy is something that we've had undergoing for the last year, 2 years now. But I think the biggest challenge for us was really to grab the data to find out where those wait times were, what kind of surgeries those folks were waiting for. And I think it's moved on into the wait care strategy of putting certain technological pieces in place in order to monitor, which has been a challenge, because a lot of these orthopods would have their own list of patients waiting for knee hip replacements, and the eye doctor would have his list, and the cancer doc would have his list, and we need to find a way to centralize this list, but at least give people choice of who they're going to, and making sure that the doctors are busy and providing the care that they want to provide. But as we look at the wait time strategy across the country, and working with the federal government right now, of trying to distinguish through the First Minister's meeting, as they've asked us to go forward and discuss this and try to come up with a strategy. We're taking orthopedics, which I think is probably the most concerning one across Canada right now, but by far the most concerning one here in Nova Scotia, as well as cancer wait times, cardiac wait times, eyes, which is cataract surgery, and of course diagnostics. I think we have gone a long ways in diagnostics and making sure that we have the correct pieces, CT scanners, and of course MRIs as we move along. And I think we're making leaps and bounds there, but they cost tremendous amounts of money in purchasing those pieces of equipment. The member opposite did talk about his patient in Cape Breton and the issues that he was having on that wait time. I think as we look at it, we provided a wait times website. The information is available to know how long each center is waiting. So if a patient can go look at that, the doctor can go look at that and maybe realize that out of the 5 centers or 4 centers that provide orthopedics in the province, you would pick the one that has the shortest time. So you're redistributing, the folks of going into those surgeries. Mr. Chair, that the Capital Region, it is known that our wait time in Capital Region right now is somewhere near the 18 months, which to me is unacceptable. Why is that happening? It has a lot to do with scheduling, has a lot to do with the availability of ORs, has a lot to do with the availability of anesthesiologists. But the wait time is less in Canville, it's less in New Glasgow, it's less in Sydney. So if we can find a better way to make sure that we flow these patients from one area to another, and and I'm sure a gentleman from Cape Breton would probably it would save him some money too to be able to go and get that surgery in Cape Breton, which is something that I want to see happen. That somebody from the valley can go to Kenville, or even finding some orthopods to go to Yarmouth would be a wonderful thing personally. But as we boil along to make sure that we have the professionals in the right areas and the availability of OR. I want to thank the member opposite for bringing up the issue of self-managed care and just say that we are doubling that pot of money this year, and so a lot more people can grab a hold of that self-managed care program. These are people that are sick or are infirm and can't receive or feel that they can't receive the type of care that they require, that they can take this money and hire the people that they require. And I think in the instances that we have been able to fund right now, I think those patients are very, very happy. And and I hope to move that program along as we go. Reading my scribbles here. Of course, we talked about long-term care and continuing care and the issue of the 100-kilometer rule, which is a very unfortunate one. But of course, to the member opposite, that you have your first request. Here's the home you want to go to. Here's your second home, the possibility that you want to go to. But in the absence of that, do you want to be in a home or do you want to stay in the ALC? And ultimately, I think it is better serving that some of these folks do go off to a true home, a long-term care facility to get the service that they deserve and they require. And then as soon as a bed frees up in their first choice, they can move back closer to home. Sometimes it takes time because of the unfortunate reason of beds freeing up, or of course some of our seniors passing away. So it is something that takes time, and it's unfortunate and sad. But it's something that as we move along with the construction of new beds in the province, that is something that hopefully we'll be able to dispose of the 100-kilometer rule as we have homes and facilities closer to home communities. Let's make sure that we know that 2/3 of the beds that we're committing to over the next the continuing care strategy are going to be constructed in the first 2/3, or the first 2/3 will be constructed in the first 4 years. There are 125 beds that are either constructed or about to be constructed, or a certain level of construction in the Cape Breton region. And also, the member opposite talked about the people he talks to say that we're only touching the tip of the iceberg in constructing the 1,300 different beds, or 1,300 new beds. But the ratio that we try to use and try to come up with some kind of formula really boils down to the percentage of folks over 75 that require long-term care. And the average, or the study that we have here in Nova Scotia and other jurisdictions across Canada sits in at about 5%. So, do we want to build too many beds? I don't think so, because it's not sustainable. Do we want a bed? Do we have the right amount of beds? Absolutely. Talked a little bit about the NSHIS, which is, of course, the health record, or the, trying to move towards an electronic patient record and making sure that patient information is shared across the province. So, if you have an injury in Yarmouth and you're from Glace Bay, that when you go into the hospital, there's your patient information. These are the things that you've had done. Here are the medications you're on, etc. So that can be better flow and better care for people right across the province. The member opposite brought up the issue of other professionals, midwives. The midwives issue is being dealt with from the department, that they are trying to design a process to set up a college of midwives, or something similar to a college of midwives. The issue and the problem we had been having up to this point is that normally in a college, in a self-regulating profession, you basically have a number of other people watching over and making sure that things are done correctly. With midwives, we don't have enough of them in the province yet to constitute a college. So we had to come up with another option to provide oversight in a short period of time. So I'm hoping to have a piece of legislation to come forward. We believe in the fall, as all stakeholders are consulted, and we have the correct piece in place. Dental hygienists is another sticky issue at this point, as we try to make sure that both sides of this story sit down and try to figure out the way through, because we have the doctors on this side, the dentists on this side that feel that it should be dealt with this way, and we have the dental hygienists that feel it should be dealt with this way. And I truly believe, Mr. Chair, that there is a solution there, and one that should be forthcoming in a short period of time. But I do look forward to also bringing some of that information forward, and it's not by chance, but it's also by lots of phone calls in my own home riding of dental hygienists that do want to see their profession recognized and treated as a true profession in its right of being able to provide care and service to Nova Scotians. And Mr. Chair, and I might surprise my deputy minister here, but there are so many other professionals within healthcare that we don't recognize that do require maybe a second look to make sure to see how they fit into primary healthcare. These are talking about the other professionals, such as naturopaths, as chiropractors, and those types of people. Well, she didn't fall off her chair. That's good. But ultimately, as we deal with making our community safer, making people safer, and making people healthier, I think we need to have the primary healthcare programs and primary healthcare systems in place. The member opposite talked about making our communities and our society healthier, which I think is what the dedication is, and what the commitment from the Premier has been in the creation of health promotion and protection, of working with healthy benefits, working with recreation, working with all those things within communities that are going to make people healthier, that will take off the strain from the acute care system. Emergency room, I think we got pretty much almost all the way down. Of course, publicly funded, which is one I think we'll probably talk about a couple of times throughout this debate. Publicly funded versus private, but the water on the beans tend to continually change on this one, as we had the Chayui case in Quebec, and how care is supposed to be administered, that if you wait over a certain time that you can go somewhere else and get it funded, and how the integration between a private system and a public system works. There's a tremendous amount of work to be done there, and a tremendous amount of searching and research to continue to be done there. I personally think that we still require a publicly funded system. That I believe in totally. The question of if there's a place for a private system, I don't know. And in the absence of not knowing, I feel that there should be some more research done. But the intention is still to bring into this House at some point, hopefully in the fall, I keep saying fall, to bring in a private healthcare act that A, protects patients, that B, protects those workers that will be required, and to make sure that we're not draining professionals away from our already taxed public system. To the question on primary healthcare transition money, which I think was the true question at the end of the story, it really is what we've used our money for, is to sustain coordinators in each DHA, number one. to sustain primary health care information system. So we have used that funding towards that NSIHIS. No? That's
federal healthcare, but it's compatible with that.
oh, the compatible. So really, as we're talking to the pieces within the clinic level,
Clinic and collaborative practice.
the clinic level and the collaborative practice, but the information systems on that. And to add additional nurse practitioners and collaborative practice groups in communities, and of course the long-term care pilot that we put into place just a few months ago at Northwood, where we have a nurse practitioner working in that facility. And of course we are planning and continue to plan on the telehealth, teletriage program that will be very similar to that one in New Brunswick, and we're talking about that planning and implementation sometimes in 2007. So with those quick comments, Mr. Chair, I will look forward to further questioning from the member from Glace Bay.
Thank you. The member for Glace Bay.
Mr. Chair, that's the definition of the minister's version of quick comments. I don't know if I want to ask him another question, but I know he's a former radio guy. But I thought so am I. We used to speak in just short sentences there. I should maybe friendly reminder for the minister, and I thank him for his comments. The additional, what I was asking, as we did get to the point about the additional $3.3 million that was spent. The additional $3 million over the next year. Some of the federal primary health care transition fund, as the minister just mentioned, was used to establish nurse practitioners. And I'd like to know if the minister could outline how much of that, the total $17 million, was used to establish nurse practitioners.
The Minister of Health.
Thank you very much, Mr. Chair, and let me give you a quick rundown of where that $3.36 million went. Two nurse practitioners in Cumberland who will be working a collaborative practice arrangement, which was about $180,000. Primary health care transition, which the funds were used to sustain and continue activities that began as a result of primary health care transition fund, leadership, infrastructure, managers, coordinators, and clerical support, which is about $2.2 million. The electronic patient record sustainable funding, and the IT support and consulting fees also belong in there. We also did a bit of diversity and social inclusion pieces, which focused on race, ethnicity, language, and culture. It's a program within the Department of Health or within primary health care that will be brought through the system, which was an investment of about $140,000. So I think that pretty much runs it. No, wait here. There's more. Expand community-based multi-professional teams, which includes the family practice nurses, dietitians, social workers, and others, which is about a project of $400,000. SPI sites, which is nurse practitioners working in collaborative practice with GPs. There's one in the South Shore, one in Cumberland, one in Pictou, one in Capital District. This funding is for salary and benefit increases due to the contractual agreements of May, which is about $84,000. Nurse practitioner salary and benefits increased due to contractual agreements as of May 2005, which is about $247,000. And finally, the nurse practitioner in Briar Island, to continue that program there as it was transferred from EHS to the District Health Authority, which was a $184,000 or so. So that does add up to $3.3 million.
The member for Glace Bay.
Thank you, Mr. Chair. I'm a little confused there, Mr. Minister. So maybe my question was, how much of that $17 million was spent on nurse practitioners? I didn't hear a figure, but if you could just wanted to confer with the deputy there for about 30 seconds, and maybe you could give us that exact figure. And you could also, if you would, answer how many nurse practitioners that we have working under the direct auspices of the Department of Health that are being paid by the Department of Health. How many of them are actually being paid by the Department of Health?
The Minister of Health.
Thank you, Mr. Chair. And I think probably the simplest thing to do here would be to commit to the member opposite that we'll provide a list to him tomorrow or so with basically a listing of where that funding has gone within primary health care and how it has benefited our nurse practitioners across the province.
The Honourable the member for Glace Bay.
And thank you, Mr. Chair. Perhaps the minister didn't hear the second part of that question, was that how many nurse practitioners do we have who are working directly under the Department of Health, and are they being paid by the Department of Health?
Okay, the Honourable the Minister of Health.
Thank you very much, Mr. Chair, and I thank the member opposite for his clarification on that question. But it boils down to right now is that we have 17 nurse practitioners practicing in the province. The funding flows through the DHAs. We are holding the money centrally to make sure that they are protected, but we do also want to make sure that we do have a really good program of nurse practitioners to move into the future. But through the DHAs, funds are being held centrally.
The Honourable the member for Glace Bay.
Thank you, Mr. Chair. So just to clarify, Mr. Minister, then what you're saying is that the nurse practitioners are now the responsibility of district health authorities, but are they paid from the district health authorities' respective budgets, or you're saying they're paid by a central budget from Department of Health? Would the minister please clarify that?
The Honourable the Minister of Health.
No, Mr. Chair, the funding for the nurse practitioners, they get paid by the DHAs, and the DHAs make the recommendations to us on where the nurse practitioners will be placed. So we look forward to their suggestions on where they feel within their systems that they require their nurse practitioners. But we do hold the funding for the nurse practitioners centrally in the Department of Health, but we flow it through the DHAs for their remuneration.
The Honourable the member for Glace Bay.
Thank you, Mr. Chair. So that there's no funding for nurse practitioners that comes from district health authority budgets. That's what you're telling me. I'll take that. Would the minister like to clarify that, please?
Okay, the Honourable the Minister of Health.
Again, Mr. Chair, is that the DHAs, they are the funder, the employers of the nurse practitioners. The money is flowed through from the Department of Health, through the Department of the DHAs to the nurse practitioner. So they are employees of the DHA, and we provide them money accordingly to pay for those professionals.
The Honourable the member for Glace Bay.
Thank you, Mr. Chair. Thank you, Mr. Minister. In June of 2005, the federal government issued a funding report on initiatives that were undertaken using the primary health care transition funding money. And according to that document, one of the expected results was the enhancement of information systems within primary health care models in preparation for electronic health records. Could the minister indicate where there have been enhancements made to the information systems in primary health care settings?
The Honourable the Minister of Health.
Thank you very much, Mr. Chair. And to outline a little bit of where that funding went, to make sure is that all districts have received some funding on electronic patient record and the Nova Scotia Health Information System. But quite specifically is that about 30% of all physician offices now have access to or have computers in them that have access to the system, and all collaborative practices at this point have the computer systems and that access in them. That's where the funding was targeted.
The Honourable the member for Glace Bay.
Thank you, Mr. Chair. In addition to the $70 million that was provided to this province directly for primary health care initiatives, Another 6.9 million, as I mentioned previously, about 6.9 million, was allocated to develop a multi-jurisdictional project relating to self-care, telecare for Atlantic Canada. New Brunswick was the lead province in this initiative. Mr. Chair, under new initiatives on page 11.1 of the supplementary detail, it indicates that one of the new initiatives would be the establishment of a province-wide telehealth system. And I'm curious, since we already have a province-wide telehealth system in our hospitals, am I to assume that this priority is a result of that $6.9 million that's spent on the self-care telecare system? Looking for a clarification.
The Honourable the Minister of Health.
Thank you very much, Mr. Chair. And there are two programs that are similar in name but different in scope. The telecare program that we have now basically is hospital connection of hospital to hospital so that doctors can see patients in remote areas. The telehealth, telecare program that we're talking about in this budget, and that was underlined, I think, in the speech from the throne, and we talked about a little bit during the last election, is basically a teletriage program, which is similar to New Brunswick, where our Nova Scotians can call in with their health issues. They would be talking directly to RNs to receive care. And what they'll be able to tell them is do this, do that, take that, but also tell the patient that maybe you should go visit the ER. And what it does show is it does bring down the number of visits to an ER by a dramatic number. I think it's somewhere close to 20 to 30% of visits to be those minor things that are upset stomach, fever, and those types of things. But it is a teletriage system versus the in-hospital remote access to specialists and physicians that exist today.
The Honourable the Member for Glace Bay.
Thank you, Mr. Chair. Perhaps the minister then can tell us what the status of that self-care, telecare system is in this province right now. Where does it stand?
The Honourable the Minister of Health.
All the operational costs are
Basically, there are two costs associated with this that we're bringing forward that speaks of it within this year's budget. Basically, the setup fee, which is about $2.5 million, with the operational per year is about $5 million. We'll see the implementation and the start of that hopefully in January of 2007.
The Honourable the Member for Glace Bay.
Thank you, Mr. Chair. Maybe the minister then could indicate, is there money allocated in this budget, in the budget for this initiative? And if there is, how much?
Minister of Health.
I guess I made a mistake. Pretty much we'll be talking about that into next year's budget because basically there is nothing in this year's budget for that implementation. So we'll be looking at next year's budget to implement the telehealth, teletriage, telecare system.
The Honourable the Member of Glace Bay.
Thank you, Mr. Chair. As I understand it, this project is a multi-jurisdictional project. So I'm wondering, does that mean when Nova Scotia, will Nova Scotia undertake this initiative with the other Atlantic provinces, or are we going to implement our own system? Is this our own system that's going to be implemented?
The Honourable the Minister of Health.
Thank you very much, Mr. Chair. And what it will be is that we did go down the road during this process of finding ways to partner with the other provinces in the setup of the program. But what it is, even at that point, we would have our own units in each province. So you would have your own RNs dealing with your issues in each province. So this represents the setup fee in our province, but still using the expertise and the backgrounding from the other provinces as well.
The Honourable the Member for Glace Bay.
Thank you, Mr. Chair. I'm left wondering as well, Mr. Minister, who's going to be responsible for actually addressing the needs to care for Nova Scotians through this system? Are you going to have, once the system is up and running, I'm sorry, you said 2007 sometime, are we dealing with trained professionals who are going to be sitting there? Or are we dealing with workers who are hired to input symptoms into a system and then read the information from a screen? What are we dealing with in that situation?
The Honourable the Minister of Health.
Thank you, Mr. Chair. And I think from my knowledge of the system and how it's going to work is there will be, of course, medical oversight from physician, but most of the, all the people that will be working in the system will be trained professionals. They will be RNs for the most part. And I think the opportunity is why we wanted to have it each our own area, where New Brunswick would have its own, we would have our own, is that we have an opportunity for some of our more experienced, and I'm experienced by age, nurses that are looking for different opportunities. As some of these RNs and nurses get along in their careers, they're looking for something different to do. That maybe they're looking for options, and this is a great opportunity for them as well. So even for retiring nurses that want to do something different, this is a great facility to them. Nurses who became handicapped, maybe have a bad back or whatever, so looking for options to still use the skills that they have. So that's the kind of professionals we'll be using within that facility.
Member for Glace Bay.
Thank you, Mr. Chair. I know my time is just about to run out, so I'm.
We have approximately 1 minute and 15
Well, I'll take that time, Mr. Chair. Thank you very much. Just a reminder to the minister that when we're talking about such a system and who's going to staff it in terms of professionals, whatever the case may be, I'm hoping the minister just isn't relying on perhaps some retired nurses will be there. Maybe they will, maybe they won't. I hope there's more of a plan in place than to provide for staffing levels of such a system. It's the same as when the minister made reference to having a website for wait times. It's great to have the website, but the website simply provides you with how long the wait times are and how many people are waiting. The actual website doesn't do anything to remedy the situation of wait times in Nova Scotia. With that, Mr. Chair, I'll take my place and allow for the next speaker.
Thank you. Chair now recognizes the honourable member for Sackville-Cobequid.
One over. Just get the move. Oh yeah, no, definitely. He wants to take a break. I can.
Okay, we'll take a recess, short recess. Thank you. One seat. So you're sitting in the Dartmouth South, Portland Valley.